So ICRU 91, it recommends the volumetric and isodose approach. That means the dose is prescribed to a isodose surface, which should cover the optimal percent of the PTV volume. And now, from where did the BD of 100 comes? In the Japanese multi-institutional study, they were trying to look at the optimal limit the toxicity and to see the local control. They found the BD less than 100 had a local recurrence of 26%, where BD more than 100 had a local recurrence of only 8%. This was way back in 2004. From there, the concept of 100 BD came. Even the survival was better and more than 100 BED. So is there any advantage of escalating or dose beyond 100, 105 or something? This was a paper published in Red Journal. It was a multi-institutional retrospective study in 65 centers having a 921 patients, 921 T1, T2. They found BD more cutoff more than 100 and more than 105 and less than 105 has a significance p-value. More than 105 has improved control. Similarly, more than 110 versus less than 110 also has improved control. So dose response continue to rise beyond even the 100 BD. And what about 150? Khoshi et al. Looked at the cases with the BD or different BD, and he found that in T1 tumors there is no advantage of escalating up to 150 BD, but in T2 tumors definitely a BD less than 150 and BD more than 150 works. So higher BD is advantageous in case of T2 tumors. So even now the Japanese have realized the higher doses needed. So they are conducting this dose escalation trial of 130 BD, 55 in 4 versus 42 in 4, as I discussed previously. What about the central tumors? In case of central tumors, this was a paper published by Ankit Mode in Red Journal. He has analyzed his data from MD Anderson, and they have found in central tumors, if most of them, their median BD was 85 gray, alpha beta 10. They found the poorer control with the BD less than 100. And then this was a systematic review by Suresh Senan, and he found that BD more than 100 still applies to the central tumors also. So we should not try to reduce the BD to less than 100 in central tumors in fear of toxicity. And interestingly, he noted that there is a dose-response relationship for treatment-related mortality also. And they advise that BD3, that means that for late toxicity, should be kept less than 210 gray for reducing, and this will reduce the risk of death by more than 75%. So we should always try to keep a BD for the tumor more than 100 and for the late effect less than 210, maybe less than 200 also. So, but still there is one unanswered question. What is the minimum BD required? Whether mean BD is important or median BD is important? That means D50 BD is important or maximum dose BD is important. And now coming on to how to decide for dose for which site. So this is called a risk adapted treatment strategy. So risk adapted fractionation is delivering the effective BED to maintain the same tumor control while lowering the risk of the normal tissue toxicity, depending upon the location of the tumor, proximity to the OARs, and tumor size. Larger tumors, smaller versus smaller tumors, central tumors versus peripheral tumors, central tumors versus ultracentral tumors. So giving different fractionation to achieve the same effective BD is called fractionation. I'm audible? Okay. So now from where this 16.3 came, as I already told, the Timmerman first Indiana study, a dose finding study where they have found more than 90% local control with 16.3. Actually, it was 54 in 3 because they did not apply the homogeneity correction. Then the Timmerman second study where they gave 60 and 66 anywhere in the lung. This was reported as an excessive toxicity study. And then subsequently the RTOG, they also gave 60 in 3. So this is the background for the no-fly zone or risk adapted. What is the no-fly zone? This Timmerman second study of Indiana where they gave 60 gray and 66 gray anywhere in the lung, they found there very good local control to the tune of 95% local tumors. But there was excessive toxicity in tumors which are 2 centimeters within the proximal bronchial tree. And 8.6, there was treatment-related deaths and 11 time increased toxicity in the central tumors. So 11 time higher toxicity in the central tumors was there. Am I audible?
Voice is breaking in between. Voice is breaking in between. Now you can continue.
Okay. So the third study by Timmerman, the first RTOG 0236, they excluded tumors around the 2 centimeters from the bronchial tree. So their definition of central tumors was 2 centimeters on all directions around the proximal bronchial tree. So to solve the mystery, there was a mystery trial by Andrea Bezeca, RTOG 0813, dose finding in central tumors. Dose finding in the central tumors. Just a minute. Am I audible, Deepak? Okay. So this mystery trial, to solve the mystery, RTOG 0813 trial was
carry on. You're fine.
Okay.
Yeah.
Okay. So RTOG 0813 was a dose finding study in the central tumors, which was dose finding study, and their definition of central tumors was 2 centimeters within the bronchial tree plus mediastinal tumor, which is adjacent to the mediastinum or pericardium. And then came the definition of the central tumors by IACLC. In this, the proximal bronchial tree, esophagus, any tumor close to esophagus, they have added esophagus, heart, brachial plexus, major vessels, spinal cord, phrenic nerve, and recurrent laryngeal nerve were included in this definition of central tumors. So you see, there are different definitions as the time progresses. That these central tumors envelope has engulfed more structures. So now what is ultracentral? If there is a PTB which is abutting or overlapping the central structures, that is called the ultracentral tumors. So what about the local control in case of these central tumors? This study I quoted previously also, Ankit Mode. From this study, we learned that BD less than 100, that means most commonly they use 45 and 5, is inadequate. GTB having a volume of more than 12 cc have a poorer control. And if it is abutting the esophagus, PT is abutting the esophagus, we should be careful. This we learned from this Ankit Mode study. And now coming on to the mystery trial 813, the starting point was 50 gray in 5 fractions. And the result of this, and in the study, the PTB was receiving 5 millimeter from the GTB. The PTB was receiving 50 gray in 5 fractions in the first level. And the OARs which are overlapping, they should not receive more than 105% of the prescription. That means not more than 52.5 gray should receive to the OAR. And this tumor was prescribed, this PTB was prescribed at 80% isodose line. So this result were published in JCO by Andre Bazag, and they have concluded that 2-year local control was very good, 89% in central tumors. Maximum tolerated dose was 12 into 5, 60 gray in 5 fractions with a 7.2% grade 3 toxicity. All groups more than 50 gray in 5 fractions had at least one dose limiting toxicity like fatal hemorrhages, fistula, and ulcer. So, and no patient in 50 gray in 5 fractions, that means 10 into 5, had toxicity. So they concluded that 10 into 5 is the safest. In the other review by Senon et al., they have in their recommendations about the central tumors, they commented that central tumors also need a BD more than 100, and late BD should be kept less than 210, and they suggested multiple fractionation in their study. 50 gray in 5 fractions, as from the RTOG 0813, 54 in 6, 56 in 7, 60 gray in 8 fractions, and there were less than 1% deaths in 60 in 8. So the no-fly zone became a carefully fly zone. So the 60 in 8 is being tested in the ERTC lung trial. So now we are safe within the, we are carefully safe within the central tumor. What about the ultracentral tumors? as we know, in the central tumor, 60 in 5 had 7.5% toxicity. But in this trial, the authors, published in ISLC, the authors, they attempted 60 grain 5 fractions in the ultracentral tumors. And in in all the ultracentral tumors, the PTB was overlapping either the main bronchus, trachea, and bronchus. So a very daring trial. And what did they find? They find a 38% more than grade 3 toxicity, and more than 40, half of the toxicity were within the 12 months. So a very high toxicity in the ultracentral tumors. So, but there is something to learn from this trial, that they found that the PTB, the minimum dose to the PTB was around, Dmax to the PTB was 123%. So that means most of these, in this trial, most of the tumor PTVs had around 80% prescription ice dose. So they suggested, authors in this trial suggested, that in case of ultracentral tumors, we should have to be more homogeneous. Rather than working on the 80% isodose, we should be working on 90 or more than 90% isodose to create a more homogeneous dose, in because ultracentral tumor is where the PTV will overlap the central structures. So the overlap area, we should be having very homogeneous dose, not more than 110% of the prescription dose, or sometimes even less is safer. So in doing that, sometimes we have to compromise on the PTV coverage. So this trial looked at the coverage. They found that local control is not compromised until if you are lowering your coverage till 85%. Normally we say about 95 to 99%, but if you are even compromising to prevent the toxicity to the central structures till 85%, you are safe. So what we learned from the previous trials on central and intracentral tumors: BD not to be compromised below 100. If needed, we can reduce the coverage up to 85%. More homogeneous dose, that means 90% isodose prescription should be practiced in case of ultracentral tumors. And esophageal and bronchial toxicity are unfogging. We should be very careful about these structures. There are other trials. And currently, one trial for ultracentral tumor is going on, which is starting at 60 grain 10 fractions. This is called Sunset trial. A starting point is 16 10 fractions. They will escalate. Is going on. So now I will be showing some cases of treating a central tumors and ultracentral tumors. This is a retired CRPF assistant commandant. Is born 1939, 80 years. CAD, central tumor. You can see is this the PTV, the GTV is in fact touching the arch of aorta. He was not fit, not in view of the age and CAD, not fit for chemotherapy, squamous cell biopsy. And on PET CT, there was the mediastinal nodes also, which was positive on biopsy. So we planned for 70 grain 10 fractions to the primary and 50 gray to the 10 fractions to the lymph node. And now the patient is on pembrolizumab. We gave him radiation in August, SBRT in August 2019. August 2019. So the PET scan, we did multiple PET scans. This PET scan in May 2020, NED at both primary and the nodes. This is the latest PET scan. You can see the date also around 2 days back. Still the patient is doing fine, absolutely no recurrences, neither at metastatic site, neither elsewhere, neither at the lung or mediastinum. So in case of tumors, in case of patients who are not fit for chemo radiation, this can be attempted because conventional radiation versus SBRT, there is no comparison. So the next patient is a T3N0 squamous cell carcinoma 60. We attempted 65 grain 10 fractions to this patient in September 2019, and you can see the response. The patient was advised chemotherapy. He did not took any chemotherapy. In last November 2020, he was diagnosed with a brain metastasis. We gave 45 and 15 SIB plus 30 grain 15 fraction to the whole brain. This is the 1 year response you can see. And this is a patient which I initially discussed, a lung tumor T1N0 for second case capsule. We gave 54 grain 3 fractions. And then 1 year later, in April 2019, he was diagnosed with a hilar node. Earlier, during that time, he had a mediastinal node which came out to be anthracosis and tuberculosis. But now he had a hilar node, you can see, and we planned for 56 gray in 8 fractions. And we were very careful regarding the bronchus because it was just sitting over the right main bronchus and the pulmonary artery also. And this is the January 2020 response. And since we have, you can see a more fibrosis in this patient because we have earlier given 54 and 3 to the lung, and then we gave the medicinal load. So there is more fibrosis in this patient. We've seen pseudoprogression also in the central. This patient received 60 grain 10 fractions because of the very close proximity to the central structures. And in April 2017, we gave SBRT. In August 2017, there was a flare up, looks like a pseudoprogression. But it has been noted. And then in June 2018 and December 2018, you can see a very beautiful response. And this is a metastasis sitting on the diaphragm, as you can see, a breast patient. I just want to show it here. It was sitting on the diaphragm. When we did this was the PET CT, and the stomach was very close. So when we did the planning CT, we made sure the patient was fasting almost for 4 hours. We can see now the stomach is almost kilometers away from the nodules. So we planned 50 grain 5 fraction to this nodule sitting over the diaphragm close to, and patient is reported to be without any toxicity. And this nodule has shown complete response. The images were done outside, so we don't have the images. So now we know where the 16.3 came. I've already discussed this. I want so just about the RTOG 20236 results. The 3-year control rates were 97%. And tumor and involved load control rates were more than 90%. 3-year rate of disseminated failure over 22%. And overall survival at 3 years of 55%. And the update was published recently in JAMA. They have been concerned about increasing recurrences in the same lobe, not at the same place, but not at the primary tumor site, but in the same lobe, different from the tumor site. So high-tech organ-specific paper was published regarding the optimal dose about the tumors. So in this study, they have evaluated and recommended the dose to the isocenter and to the PTV edge. Both different type of prescriptions you can follow. Isocenter dose and PTV edge dose in 3 fraction, 4 fraction, 5 fractions, and T1 and T2. Their recommendation was we should be cautious if we are giving a low dose of 42 grain 3 fractions. For T2 tumors, we should always try to escalate dose at least above 110 BD. And for patients, they have recommended that for patients with long overall survival expectancy in 3 fractions, that means 54 gray in 3 fractions, this should be considered. They are the ESTO guidelines regarding the minimum ECOG performance stages, motion management. I will skip this. And the same consensus guidelines, they tell about the risk adaptation therapy, strategy, peripheral location 15 in 3, minimum dose, broad chest wall contact 48 in 4, central location 60 in 8 fractions. So now adaptation about lesions which are abutting the chest wall or more than 5 centimeters. This is a paper from MSKCC where there is a skin toxicity. So rib fracture, and the pain is maybe because of the injury to the intercostal nerve. Onset is around 9 months. There is variation in the incidence and predictor because they are different definition of chest wall. The RTOG recommends a chest wall 2 centimeter strip, as you can see in this, and many people they mark only the vertebrae. So in Seminars Radiation Oncology published in 2016, they have modeled the chest wall and given the constraint for chest wall toxicity. They have said that for chest wall, Dmax is not so important. More important are the D2 dose received by 2 cc of the chest wall, D30 cc, D70 cc. And they have given the constraint for 1, 2, 3, 4, and 5 fractions for 2 cc, 70 cc, D20, that means around 30 cc, and D50. For 5 fractions, D2 is around 50 gray to limit the toxicity to 11%. So we had this case, gentleman T3N0. So we were planning to give him a 55 to 60 gray in 5 fractions. And so So the constraint, the previous constraint of 2 cc 50 gray cannot be achieved in this case, because you see the GTV is eroding the chest wall and ribs. PTV would engulf the larger volume. So 2 cc 50 gray can never be achieved in such case. So what to do? This is a clinical dilemma. We went ahead. We went ahead with the 60 grain 5 fractions with 75% ISO. Was most important thing we kept in mind not to increase the skin dose. And you can see the beautiful response. So the MSKCC Chang et al. Group, what they have to say regarding these scenarios. Lesions next to chest wall, we recommended more than 95% of the GTV plus a 5 millimeter margin should receive at least the full prescribed dose, even if the chest wall dose exceed 35 gray to 30 cc. In our practice, 35 gray to 50 cc is allowed for lesions close to chest wall, unquote, by Chang et al. So chest wall toxicity is a concern, but not to at the should not be compromised. It can be compromised, and priority giving should be given to the GTV dose and GTV coverage. But skin toxicity is unforgiving. I will show you one case: the elderly patient with squamous cell carcinoma, chest wall lesion. It was very close, and the PTV was just overlapping the brachial ox also. We give a constraint to brachial plexus and see the response. And the patient developed a liver metastasis. And segment 3, we gave SBRT, it responded beautifully. And then patient had the other liver metastasis. We advised them for SBRT to other liver lesions also, but medical oncologist preferred otherwise. He was on immunotherapy, chemotherapy, disease kept on progressing. And this is the 16th February 2021 PET CT on the right hand side. This one, you can see the primary tumor NED, but the liver lesions continue to increase, which were not given radiation SBRT. So we had a couple of few rib fractures, but mostly they are non-painful and they heal by themselves. As you can see in the right side, there is a rib fracture. So, and this is a very case which I always want to show. This is a patient. We will call this as a chest wall tumor or a central tumor. Central is, I would prefer to call it more as a central tumor than a chest wall tumor, because although it is invading the chest wall also, it is invading the vertebra also. It is a T4N0, because chest walls, the central structures should be given more preference. So this is a central verse and a chest wall tumor. Is a T4. We planned for 60 grain 8 fractions. Had it been only a chest wall, we would have gone for 5 or 6 fractions, but we went for 8 fractions. T4N0 tumor. And you see this above was in May 2019 when we planned for radiation. This is January 2020 complete response. And in mid of May 2020, he developed a mediastinal node. And then at that time, we realized that he had got a diaphragmatic palsy. I will show those slides also. And this is the most current PET scan, which is done in 2nd of February 2021. So 20 months follow-up, still NED. Except in mid 2020, he had a nodal recurrence in the mediastinum, which is now ending. But still, he complains of around pain over the back, where he is pointing around 3/10 score of pain, which is controlled with analgesic. This is another chest wall and central tumor invading. We gave these fractions, 7 fractions SBRT in these 56 and 7. And this is the same patient, both the images are, and this is the post-treatment SBRT response. This tumor was invading. The patient was 81-year-old with ejection fraction of 15%. Severe pain because of the invasion of the sternum, chest wall, and also encasing the central structures. It's T4. So, and the patient expired in December 2020 because of some sepsis. He was on immunotherapy. So the dose adaptation is in case of peripheral tumors, 1 centimeter away from the chest wall, less than 2 centimeters, 1 fraction, 24 to 34 grade, 3 fraction. If it is 3 centimeters, I'm okay. 3 fraction, 45 to 60 grade, 3 to 5 centimeter tumors, which are invading the chest wall. If it is 4 to 5 fractions, 48 50. So this is dose adaptation. For central tumors, they are different for 50 gray, 54 gray, 56 gray, 60 gray, 70 gray in 5, 6, 7, 8 fractions. So I will skip this. There is the East. This is from the Green Journal, where they have recommended that the coverage is important. At the same time, T max should be 125 to 150% in case of peripheral tumors, non-central tumors. Within the that means at least 80% isodose prescription should be given. And they also suggested to report D28, D98, and D2. And now I have got around 10 more slides there. So radiation pneumonitis, I will just skip this. I think I want to just tell you what is the ground glass opacity and consolidation. On the left hand side, in case of you can see here, this ground glass opacity is where you can see the background vessels and bronchial structures, and consolidation is on the other extreme end of the CT, where you can't see any background thing. There is something called air bronchogram, where you can see the air within the bronchi. This is on right side, because these changes are there important for the assessment of changes. I will show you. So early CT findings are, it is a mixture of, nothing to get confused. In early CT finding post SBRT, which is usually seen within 6 to 9 months, you will see consolidation, you will see ground glass opacities, you will see air bronchogram. It is a mixed pattern. And what about the late? In late CT findings, you will find the consolidation, mass-like pattern, and scar-like pattern. This is a patient which we treated, and you can see the serial follow-up lung consolidation, 3 months, 6 months, 12 months, and 9 months. And this was at 24 months. You can see in 24 months now the fibrosis has set in, and there is a pulling up of the mediastinum towards the right side. I will skip this. Yes. So this is the another high-tech paper on lung parenchyma doses in SBRT. They recommend a V20 of 10 to 12%, mean lung dose, combined mean lung dose of 6 to 8 gray. And Guckenberg et al. Has given EQD2, mean lung EQD2 of 9.9. That means a BD 3 of around 16 gray, irrespective of the fractionation tooth, because this is for either 3 fractions or 5 fractions or 1 fraction. And there is a matrix for mean lung dose V5, V10, V20, V30 of combined and ipsilateral lung. I'll skip this. So esophagus toxicity constraint has been recommended for esophagus toxicity from 3, 4, 5, 6, and 7 fractions. For the central structures like the aorta, it is most resistant aorta, and toxicity are we should limit the Dmax around 51 gray in 5 fractions. And the same patient where it was a central and a chest wall invading tumor, we saw diaphragmatic palsy. I want to show this. So after this treatment, this tumor was at the level of T3 and T2. So diaphragmatic nerve, the phrenic nerve is going from here. After SBRT, there was complete response, but when he had a nodal recurrence, we again planned the patient for ABC treatment. We did the breath hold scans. On the left hand side is the initial scan, breath hold scan, inspiratory breath hold. You can see both the level of diaphragm are the same side. But on the right hand side, when after giving the SBRT to the mediastinal mass, to the lung mass, when we did the ABC simulation scan, you see the position of the diaphragm, it is up. So we repeated 3 or 4 scans. In all the scans, the diaphragm was at the same level. So we did the PFT. PFT was 77% predicted. So patient is completely asymptomatic with this diaphragmatic palsy, but it is because of the SBRT. But the tumor has gone. So predictor of local failures are larger tumors, squamous histology, lesser BED, increased fractionation, higher pre-RT SUV max, residual SUV max of more than 5 after treatment. And they are high-risk features, enlarging opacity, and they are 5 or 6. If there are more than 3 features, there is high risk of probability of recurrence. Algorithm how to solve this. And pattern of failure, most in SBRT, most common pattern of failure is distant and regional nodal occurrence. Local occurrences are very less. So take home message is Peripheral tumors go for 3 to 5 fractions. We have not tried a single fraction till now. Prescribe at least 100 BD, preferably 120 to 140 BD for peripheral tumors with a lower isodose prescription of 80% or lesser. And preferable mean dose to the PTB would be somewhere around 120 to 140. Central lesions, 100 BD, but we should try to achieve a BD late of around less than 210. Homogeneous plan, 90% or more than 90% isodose prescription should be applied. For T3, T4 tumors, try SBRT, followed by chemo immuno, because they will fail elsewhere. Discuss all your results with the medical oncologist. Have you seen most of the cases have been referred to a medical oncologist, always squamous cell carcinoma. Only 1 or 2 cases where in those what I have shown are adenocarcinoma, because they prefer to keep adenocarcinoma with them. Squamous cell carcinoma, they know they are overdoing, they send those. But when we discuss our cases with them, now they start believing the SBRT works even T3, T4 also. For poor performance status, not fit for conventional fractionation, chemo radiation, then I would prefer, or we would prefer to do it SBRT to the primary tumor and a hypofractionated RT, if not SBRT, to the mediastinal nodes. So I would like to thank our mentor, Dr. Kataria, and our team, Dr. Deepak, Dr. Kushal, Dr. Manoj, and Dr. Sushovan for contributing and giving their valuable input. Thank you so much.